Hi, I'm Tyler Ayala from Advocate Christ Medical Center. Today we will be demonstrating the procedure for ultrasound-assisted lumbar puncture in infants. Hopefully, once we're finished with the technique, you'll find it's a useful adjunct to your existing clinical practice.
Infant lumbar punctures are the most commonly performed procedure in children, with over 90,000 performed each year in the U.S. Lumbar punctures can be challenging to perform on infants for several reasons, including many emergency physicians have relative inexperience with performing infant LPs compared to adult LPs. Infants can be more difficult to position and are also less likely to remain still for the procedure, and their overall anatomy is smaller, including the CSF space. However, the same limitations of size that can make infant LPs difficult are advantageous with ultrasound because compared to adults, the entire spinal anatomy can be visualized in infants. This is because the bones of the infant spine are not yet fully ossified, and there is typically less subcutaneous tissue. This creates an excellent acoustic window to view the structures of interest. There are several advantages to performing ultrasound-assisted LPs. First, ultrasound carries no risk of harm to the patient. The physician has the ability to identify important structures to avoid, such as the spinal cord. Traditional LPs are performed blind, so the ability to visualize the important structures of question is quite useful. Importantly, the physician has the ability to quantify the amount of available CSF, the target, if you will. Because the ultrasound is done prior to the procedure, there is no technical difference in performing the actual LP. This particular technique is not a real-time ultrasound technique. Also, using ultrasound may help to improve the success rate of the procedure. One pediatric study has demonstrated that ultrasound is useful in failed LPs where it identified hematomas and areas of minimal CSF, which then guided subsequent management. There is at least one randomized study in the adult literature that has shown that the success rate is significantly increased when performing ultrasound-assisted LPs in obese adult patients. Currently, no similar randomized trial exists for infants. However, the authors of this video are conducting one such study at present. The objectives of this video are to highlight the technique for performing ultrasound of the spine in infants, to identify important spinal structures when performing the ultrasound, to recognize the size of available CSF for a given interspace, and to recommend a technique for marking the skin. For setup, you will need your facility's bedside ultrasound machine and a skin marker or pen to identify landmarks. Today we will be using a Zanari 1 ultrasound machine. Also have your lumbar puncture equipment and personal protective gear ready at the patient's bedside to use immediately after the procedure and minimize patient movement. The LP will be performed sterilely, but ultrasound identification of structures need not be sterile. In infants under 6 months, the entire spinal anatomy can be readily visualized with ultrasound. Around 6 months, the ossification of the spinous processes begins to make identification of structures more challenging, though imaging is still possible up to 1 year of age. The infant in this video is 9 months of age. As in a normal LP, locate the iliac crests and use them as a landmark to approximate the L4 vertebrae. The spinal cord is marked to aid in probe positioning. Remember, in the young infant, the cord typically terminates at about L3. To begin, position the patient as they will be during the actual procedure. It is typically easier to position neonates in the lateral decubitus position, but larger infants can be positioned upright. Utilize an assistant to keep the patient in position with the gluteal fold in line with the spinous processes, and keep the hips, knees, and the spine of the patient all flexed. For the ultrasound, you will want to utilize your machine's high-frequency linear probe. Pay attention to the depth markings of your probe. You should need no more than 3 to 5 centimeters of total depth to visualize all the structures in question. Adjust the depth on your machine to get a good view of the entire spine. In this image, we can identify several things. The hyperechoic structures closest to the probe are the spinous processes, creating shadows. The deep hyperechoic structures are the vertebral bodies. This hyperechoic stripe is the dura, and just outside of that is the epidural space. Here is the subarachnoid or intrathecal space containing black hypoechoic cerebrospinal fluid. In this next image, we will see the termination of the spinal cord or the conus medullaris. Just distal to the conus, you can see the strands of the cauda equina. Note that you can actually see the termination of the spinal cord, so you know not to puncture cephalad to this. This is another image showing a small pocket of CSF with the spinal cord lying deeper. Learn to use landmarks along with your imaging to improve success. Ultrasound is particularly helpful because you can see the depth at which you should enter through the dura and arachnoid mater, and also how deep you can go before you get beyond the intrathecal space. Here we see we should expect to be entering the subarachnoid space at a depth of about 1.3 centimeters to the skin. The actual depth of available CSF for this inner space is 1.2 centimeters, and if we have gone beyond 2.5 centimeters to the skin, we will not be able to obtain any fluid. Remember or write down these depths as you are performing the puncture. Knowing this will help limit the amount of needle movement, thus decreasing chances of a traumatic or unsuccessful tap. Documentation on the skin is a personal preference, but we recommend you first center the image over a desirable inner space. Centering the image is an important step. Next, place markings on both sides of your linear probe. Rotate the probe directly over that inner space 90 degrees. Ensure again that the axial image of the cord is centered on the screen, and then make markings on both sides of the probe. When you are finished, you will have a target to insert your needle. You can also make marks for another inner space if you desire. After the skin has been marked, the ultrasound gel can be removed and the back can be prepped over your markings. Use caution with normal pens and markers as they can be washed away. Another option is to perform LP with real-time ultrasound guidance, but it is more time-consuming and may be limited by probe size and availability of an assistant operator. And that's it. Hopefully you will find ultrasound to be a quick and useful tool in performing lumbar punctures in the neonatal and infant population.